thought I might move on with my own presentation, which is not really my presentation because it's really the highlights of presentations made by Professor Kelly Parsons. And Kelly was also a fascinating guest, international guest at the meeting this year. Not only is he a urologist, he's also very much a clinical trialist. And the other thing which is of interest is that he's an author as well, and he's written a couple of novels. And for one of them, I understand he's actually sold the movie rights for that. So we'll have to wait and see if that ever becomes a movie. And he has warned us that if we're not careful, that we may be the subjects in his next novel. So I've personally known Kelly Parsons for probably about 10 years, and it was quite interesting how we met. In that I actually met him at an AUA meeting, but I met him in a elevator. We were both heading to the same meeting, and it's like one of those moments where we're the only two in the lift. We look at each other's badge, and we go, "Oh!" You know, it's like we both knew of each other, but had just never met before, and we just hit it off, and we've been very good friends ever since. And so it was particularly pleasing to see him come along to the meeting as a guest. Actually, I've got to tell you a little story about how he came to our meeting, in that at the very first organising committee meeting for Brisbane, I'd suggested at that meeting that maybe Kelly Parsons would be a good guest. And then no sooner had that meeting finished, I suddenly get this direct message from Twitter. And Kelly had been watching the Anzac feed, and he writes down, "Hey, dude, where's my invitation?" And so his invitation was sealed. All right, we might move on. So Kelly Parsons is a professor of urology at the Moores UC San Diego Cancer Center. Now, one of his presentations was with regard to lifestyle and diet for prostate cancer, but in particular I'd like to draw special attention to a clinical trial where he was the principal investigator. This was known as the meal study, and it involved randomising men to receive either supportive dietary modification advice from a central telephone call centre, or just simply following a booklet which was known as the Nutrition, Exercise and Prostate Cancer Book of the PCF. There was a total of 443 subjects who enrolled, and it involved 91 sites, both academic and community. And it was interesting, about a relatively low number, 12% were African American, and not surprisingly, there were very few men who had Gleason score 3+4, since this was a study looking at dietary modification for the effects of diet on men on active surveillance. It's actually a miracle that anybody in the United States has actually been on active surveillance with his Gleason score 3+4. So the primary endpoints for the meal study were having a PSA that went up to 10 nanograms per mil, or a PSA doubling time that was less than 3 years, or pathological progression. The aim with the diet was to have subjects take have at least 7 servings of vegetables per day, and you could see that they came close to achieving that, but it's very difficult to have people really stuff vegetables down their throat, and there is a limit. It's interesting when they look at the lycopene intake, and the main source of lycopenes is going to be cooked tomatoes. You can see that was probably it was a little easier to achieve a consistent difference. I think everybody loves tomatoes. Look at fat calories, and you can see that with constant support from a call centre to the patients, that they were actually able to reduce their caloric intake. Look at the blood carotenoids. I presume that means carrots, so you can see better at night. But anyway, it's all that carrot, and the carrot secreting gland in the stomach, as we all know about. But anyway, that aside, at 12 months, there was quite a bit of success in increasing the carotenoid intake. So let's look at the primary outcomes of this study. If you look at the time to progression, hazard ratio 0.96, and you look at the pathologic progression, which was a secondary endpoint, hazard ratio 1.39. In other words, it didn't make much difference. So the take-home messages from this study were that large-scale behaviour change for prostate cancer is feasible, and it's certainly been shown, but there's no effect on disease progression, and the longer-term effects of this are unclear. Kelly also presented a little bit of data on some other studies which looked particularly at diet, and that most of them were negative studies. But when we looked at some of the exercise studies, for example, here's a study from JCO that looked at exercise and risk of prostate cancer-specific mortality. And what you can see is that whether you exercise, say less than 1 hour a week or 1 to less than 3 hours a week, didn't really make much difference, but you really had to, go for it with more than 3 hours of exercise a week to perhaps make any difference. And when you look at this particular study from Cancer Research, you can see that on the left-hand side, whether you walk, whether you did 3 hours or more of walking less than 3 miles per hour a day, didn't seem to make any difference. So if you walked less than 3 miles per hour per day, 3 miles per hour when you walked, it didn't make any difference how much you walked. However, once you got the pace up, then there was perhaps a little bit of difference. So what can we say about this? Well, the benefits gained are only with fairly intense exercise, and this is also only observational data. Now, what about resistance and aerobic training for patients who are on ADT? Don't worry about what's on the table there from this paper from the Journal of Clinical Oncology. The key message is that, well, there's benefits in bodily pain, general health, vitality, and physical health. However, there's no evidence overall that diet or exercise will alter disease progression. So a little bit disappointing. An important thing is that telling patients to eat a healthy diet is okay, but saying it will treat prostate cancer is not. And an overall take-home message is that clinical trials probably should be focused on quality of life outcomes rather than survival outcomes, which tends to be what we have focused our endpoints upon. Kelly also gave a presentation on some clinical trials for localised prostate cancer, and it was very interesting to get his take on opportunities for intervention trials. So what he did was he presented this graph here, or this figure here, which shows the spectrum of disease risk. And he first drew our attention to very low-risk prostate cancer. And quite correctly, he stated that it's not a very good opportunity for trials because almost all men are suitable for surveillance. And the other thing is it's very low event rates. He then drew our attention to high-risk prostate cancer. And we all know this is a tremendous opportunity. There's a lot of neoadjuvant and adjuvant therapies that we could try. There's also the whole question of oligometastatic disease, and it's becoming an increasingly crowded and complicated space. However, when we have a look at the low and intermediate risk groups, and particularly those who have the favourable intermediate risk prostate cancer, this represents a tremendous opportunity. It's an opportunity to test novel interventions, particularly for those who are going to be managed conservatively, and it's an uncrowded and developing space. So with this particular group, one of the things we're starting to see is an emergence of a number of trials where they're looking at grade progression and comparing novel interventions versus active surveillance, so not so radical treatments. I guess at the forefront of these novel interventions is really focal therapy for prostate cancer. And another thing we're observing with these trials is that they tend to look at patients who have got favourable intermediate risk cancer or better. Now, a trial that Kelly has been a principal investigator of has been the ProstVac study, and this is one of those what you call immunotherapy types of studies. And the protocol was recently published in European Neurology Focus, and it's known as an IPASS study. In other words, immunotherapy to prevent progression on active surveillance. Now, the key eligibility criteria for the study are biopsy-proven prostate cancer, clinical stage less than or equal to T2A, less than 50% on the random biopsy cause positive for cancer, biopsy Gleason score better than or equal to ISUP grade group 2, PSA less than 20 nanograms per mil, and no prior treatment for prostate cancer. And the primary outcome is the change in the CD8 plus and the CD4 plus cells in the stroma adjacent to the tumour and within tumour. And the secondary outcomes are PD-L1 expression, PSA grade, and proportion of men with no tumour on post-intervention biopsy. And it's probably the last one there is probably one of the greatest interest to clinicians in this room. The general schema of this study is you can see that patients are identified from on active surveillance, and then they receive 5 months of regular injections with Prosvac or placebo over a 5-month period of time, and then at roughly the 6-month period of time, they undergo biopsies and enter into a period of follow-up. And this is the progress they've made. This is the progress they've made so far. They've randomised 154 patients, and it's ongoing. The accrual has been very impressive. They're currently 6 months ahead of schedule, and so it really shows that men in this group are very interested to be participants in clinical trials. So that's something to bear in mind. When we look at the baseline characteristics, again, don't worry, don't get too fussed over the detail of this table, but the thing of particular interest is that we've got something like 34% of the men have grade group 2, which is absolutely fascinating. Because you think of active surveillance studies in the United States, you think there'd be hardly any. And when you compare this to the meal study that we talked about just a few moments ago, it was only less than 2% of the patients had Gleason score 3+4. So this is preliminary data, and on the left-hand column, the pre-column, of course you're not going to have any patients who will have no tumour on their biopsy, and none of them will have greater than or equal to 4+3, because that was an exclusion criterion. However, it's interesting when you look at the range of biopsy results in the patients treated so far, where you have 35 patients have no tumour on their progress biopsy, and you even have a number who have upgraded, but that's probably not surprising. You have to bear in mind that they don't have ready access to MRI or PSMA PET scan in the United States. And let's see, in terms of positive random core biopsies, in terms of tumour extent, there was a greater percent. Sorry, it was pretty similar sort of percentage of positive cores. We'll get that out the way. When we look at the PSA, not a huge difference. So the key point is that there does seem to be some differences emerging, but it's very early days, and Kelly anticipates that we're going to see the final report of the IPASS study sometime about now, actually. So it was these are figures from back in July, so they've obviously made, they were anticipating that they would be making a lot more progress between July and now. So Kelly's presentations did surround a couple of those very important randomised controlled trials that he's been the principal investigator. So it is pretty amazing to see a busy clinical urologist so embedded in clinical trials. We also had this wonderful session at the what do we call that Sunday night function? The evening symposium, where Kelly was interviewed by another author amongst our membership. I'm not sure how many of you are aware that Professor Howard Gurney, who's a medical oncologist in Sydney, is also a fiction writer. And it was fascinating to see Howard interview Kelly, because if I was asked to interview Kelly about his books, I wouldn't know what questions to ask. But Howard, as an author himself, was able to understand exactly what... Howard knew the questions that we would like to know the answers to, but didn't know what to ask, because there was no better person than another author. So I think that all you've been able to see that Kelly Parsons was another one of these wonderful guests, and it's just a taste of what to expect at next year's meeting. All right, thank you very much for your attention.